Hi, everyone, and good afternoon. I'm Jennifer Walsh. I'm a senior media officer with the Institute of Medicine. On behalf of the Institute of Medicine, I would like to welcome you all to this afternoon's briefing. We are here to discuss the new report that was just released, Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. This report is now available and it can be downloaded as a free PDF along with related materials that go along with the report at www.iom.edu. Just a reminder, this is going to be a 1-hour briefing unless we run out of questions beforehand. We will start off with some opening remarks, and then the co-chairs of the committee that wrote the report will give an overview of the report's findings and recommendations, and then I will open the floor up to questions. And with that, please let me introduce Dr. Victor Zhao, President of the Institute of Medicine.
Well, good afternoon and welcome. Thank you all for being here and to learn more about our new report, Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life. I'm really pleased to release this report. It has such great relevance to the national debate and that ultimately will impact all Americans as we and our loved ones walk through the inevitable final stages of our lives. So many of us have dealt with family members and friends during their last days of life. It's a tremendously difficult experience, and we all need as much support as possible as we prepare to part with people that we love. Because that's such a personal experience, it can often be a very difficult topic to approach. We all know there's a lot of controversy surrounding the end-of-life care, and that was particularly politicized during the passage and implementation of the Affordable Care Act. But we cannot let our discomfort in discussing care during dying lead us down a path of inaction. Today, the U.S. is more culturally diverse than ever before, requiring the need for patient-centered care that is tailored to individual preferences. This is particularly important during our last few days when we see the surfacing of unique family structures, traditions, religious beliefs, comfort preferences, and emotional, mental, and physical needs. We also have extreme health disparities within this country, and these extend into access and use of hospice and palliative care, for example. And the number of older Americans who are frail, have physical or cognitive disabilities or chronic illnesses is really increasing rapidly. The number of individuals over the age of 65 was 39.6 million in 2009, and by 2030, this number is expected to be 72.1 million, about 14 to 19% of the US population. So, what's the problem here? Our current system is not yet equipped to deal with these challenges. Too often, communication between patients, families, and clinicians is weak, and patients don't die in the manner they really prefer. Our service delivery is fragmented with poor support, lack of payment incentives, and poor coordination across the programs. There are too few palliative care specialists, and of course, the knowledge of palliative care, end-of-life care among the clinicians is really inadequate, as you hear from the report. Now, the good news is that we are seeing more and more evidence that our healthcare system is ready and eager to change. A recent New York Times article quoted or noted that private insurance have begun reimbursing doctors for advanced care planning conversations, and the American Medical Association, the largest association of physicians and medical students in the US, recently developed a billing codes for the end-of-life conversations, submitted them to, in fact, Medicare for approval. I certainly believe our providers and insurers are ready, as are patients and their families. And the political environment is changing too. The late author and professor Maurice Schwartz said, and I quote, "Maybe death is the greatest equalizer, the one big thing that can finally make strangers shed a tear for one another." End of quote. So rather than let this topic divide us, let us use this as an opportunity to connect. Once we have acknowledged our common humanity and experiences, now we can move forward to tackle this challenge together. And this is why I think this report is so important. This report serves as a base on which we can build our plan for how best to serve our family, loved ones, and friends as they near the end of life. Now, the IOM, we're very fortunate to be responsible and pulling together the committee that work on this report. We are a nonpartisan, non-government institution, and it is important that we are neutral and think what's best for the nation. It is part of the National Academy of Sciences, which, as you know, was established by Abraham Lincoln and the Congress in 1863 to independently advise our nation based on available evidence, and that's what this committee has done. We take great care to ensure that committee members who develop our reports represent multiple perspectives and have no conflicts of interest that will blur the decision-making processes. And our study and external process, review process are rigorous, with the aim that final report convey the relevant available evidence in a dispassionate and reasonable manner. With that being said, I believe that this report is one of the most comprehensive and up-to-date studies that has been performed on an end-of-life care for people of all ages, young or old, who are approaching death. Healthcare delivery for people nearing the end of life has changed remarkably since our last report by IOM in 1997 called Approaching Death, Improving Care at the End of Life. Since that report, the number of palliative care teams within hospital setting has increased, and palliative care is established in the professions of medicine, nursing, and social work. So the time is now for our nation to develop a modernized end-of-life care system, as envisioned by this report that you hear. So before I move on, I'd really like to thank so many people who make this possible, particularly across the committee. We have just a great committee with people with all different perspective, walk of life, and co-chaired by, of course, Dr. Philip Pizzo and Mr. David Walker. They are here today along with several other committee members, Linda Schaefer, Judy Perez, Pierre Rees, I'm told, James Towski, Jim Cudner, and Bill Navalli. I also like to thank the IOM staff who worked tirelessly behind the scene, researching, writing, organizing meetings, and of course leading the committee through many, many deliberations. Adrian Stith Butler, Stephanie Pincus, Lauren Schern, Bradley Eckert, and also Thelma Cox. Finally, I would like to say that we are very grateful to an anonymous donor who identified this pressing issue and funded this project. This donor, who remained anonymous, have given us additional funds for dissemination of the finding so that our message can extend the reach of the public, the government, and elsewhere. Other than providing financial support, the donor had no role whatsoever in the selection of committee members, in deliberation of the report. In fact, the donor is not even privy to the recommendations until now. So we are grateful to this generous donor who obviously believed the right thing to do is to support an important initiative such as this. So I want to thank all of you again for being here. And without further delay, first I'd like to show you a message from Dr. Harvey Feinberg, the former president of IOM, who obviously term ended past June. However, he was very instrumental in investing in this report, and he has joined us in spirit from the West Coast. So can I see the videotape, please?
Hello, I'm Harvey Feinberg, former president of the Institute of Medicine. It's my pleasure to welcome you to today's release of the report on dying in America. Of course, this is not a new problem. Back in 2009, legislators from both sides of the aisle in the House of Representatives attempted to introduce a provision that would have become part of the Affordable Care Act that would have provided payment to Medicare for doctors and hospitals who would counsel patients on their options at the end of life. At the time, pundits, bloggers, other commentators, and other legislators declared that this was introducing death panels and that the law would eliminate choice on the part of seniors facing the end of life. This provision never found its way into the law. Sometime later, when Don Berwick was the commissioner of the Centers for Medicare and Medicaid Services, he attempted to authorize payment for doctors who, in their annual examination of patients, would counsel those patients about their options at the end of life, advance directives, living wills, and the such. This provision was to go into effect on January 1st of 2011. By January 4th, the administration had withdrawn this provision. Doctors, of course, could still talk to patients about their options at the end of life, but they could not bill Medicare for those services. At a time when our political leaders refrain from talking about a subject as important as end of life, it's incumbent on others of us to take up the question and to deal with it ourselves. Every one of us is going to face the end of life. Many of us have already faced many hard decisions for parents, for children, for a spouse, for a loved one, for a dear friend, at their ends of life. We know it can be a very difficult, emotionally trying time. We can do better in making sure that every one of us will have their preferences recognized and honored for the end of life. The Institute of Medicine has taken up this question. We were very fortunate to have the benefit of a very generous donor who wished to remain anonymous and who supported this study. We were able to assemble a diverse and highly qualified committee. We were fortunate to gain the benefit of two very able co-chairs and to have a dedicated staff who could work on the project throughout. We hope that the results of their work, today's report, will stimulate public discussion on this important topic. We believe that reasoned public discourse is the way to face up to the real and urgent challenges that we face in the ends of life. We hope that this report will contribute to a system that will honor the preferences of every individual and family at the end of life. Thank you very much for being with us today.
Well, I would like now to introduce the co-chairs to lead us through a discussion of the report's recommendations, and the other committee members will be very happy to take question and answer. So first is Dr. Philip Pizzo, who served as the Dean of School of Medicine and the Naumann Professor at Stanford University School of Medicine from 2001 to 2012. He is currently the founding director of the Stanford Distinguished Careers College and the Heckman Professor of Pediatrics and Microbiology and Immunology at Stanford. The other co-chair is Mr. David Walker, who founded and served as CEO of Comeback America Initiative that promote fiscal responsibility and sustainability by engaging the public and assisting key policymakers on a nonpartisan basis to help achieve solutions to America's federal, state, and local fiscal imbalances. Previously, he served as the 7th Comptroller General of the United States and was the head of the U.S. Government Accountability Office for almost 10 years. So let me turn the microphone over to the co-chairs, and they lead you through the report. Thank you, all of you, for being here. Thank you.
Thank you, Dr. Zhao. Appreciate it very much. I want to thank all of you for being here. My name is Dave Walker. I had the privilege of being able to co-chair this report with Dr. Phil Pizzo from Stanford. The first thing we want to do is introduce our other panelists who will be involved this morning before we go through the presentation. On my right, Leonard Schaefer, who is Judge Robert McClay, Widening Chair and Professor at the University of Southern California. Judy Perez, Clinical Social Worker and Policy Consultant. James Tulsky, who's Chief of Duke Palliative Care. And then on Phil's left, Gene Kuttner, who is Chief Medical Officer for the University of Colorado Hospital. Bill Novelli, who's Professor for the McDonough School of Business in Georgetown, former CEO of NERP. And I also want to acknowledge that Naomi Karp is another member of the committee who joined us this morning. She's with the Consumer Financial Protection Bureau. What we want to do now is to give you through an executive summary of the scope of the report, its major findings and recommendations. But before we do, some of you may be wondering about what this colorful tie is all about. And I think it's important that we understand that while we're here to talk about a very important end-of-life issue, this is a very significant day for the United States. This is the 225th anniversary of the adoption of the greatest political document in the history of mankind, the United States Constitution. So now, if we can, let's turn it over to Dr. Pizzo and see where we go from here.
Well, thank you very much. I can't outdo you in a tie. This is a Stanford tie. I don't know whether that trumps the Constitution or not. Well, thank you again for being here. It truly has been an honor and privilege to work on this report with such an outstanding group of individuals and to learn from and contribute to what is certainly an extraordinarily important topic. You know, as I look around the room and reflect on all those who are watching us on the webcast today, we come from all different walks of life. We have different life journeys and trajectories, but we share in common one reality. We're all going to die. And so that reality really compels us to think critically and forcefully about how we're going to think about the ways that we can make this experience achieve individual choice and preference and accomplish outstanding and compassionate care in the United States. We think, as Dr. Zhao already articulated, that we have the ability to accomplish this. But we also believe that we have a long ways to go and we need to overcome many impediments. You've heard some of them already. We know that in the last century, there has been a shift in the way death has taken place from home to hospital. We recognize that many people simply don't have the opportunity to have their own wishes fully carried out. And then in the absence of that, many things are done to them and for them that if they'd had the choice, they would have not had happen. We recognize that we're in the greatest demographic shift in our nation's history since the time of the signing of the Declaration of Independence, Constitution, and every other document. We are witnessing a movement such that by 2030, 20% of the U.S. population will be 65 years or older. And that these changes encumber us and require us to think critically and carefully about the choices that are being made, because among that population is an ever-increasing diversity and in some cases a widening gulf in terms of how people perceive care, receive care, and think about end-of-life choices and issues. There are many challenges that stand before us, individual choice being among the most, but aligning clinical practice, public policy, and personal preference is what we seek to do and which was the ultimate driver of our report. As you know, those of you who have witnessed other Institute of Medicine reports, we were given a scope of task, a set of charges to delineate. And we worked very hard to respond to each of those and to consider each in detail with as much evidence and critical thinking as we could bring to bear. There are topics that we didn't review and discuss because they were outside of that scope. They're important and may become issues for future committees. But among those that we were charged with was following the 1997 report that Dr. Zhao referred to and the 2003 report on when children die, we needed to refine what's been accomplished since in really the delivery of medical and social supports, the role of patient-provider communication of values, advanced care planning, healthcare costs, financing and reimbursement, education, health professionals, patients and loved ones, and really the public at large. And that becomes incredibly important given the political issues that we've already discussed. As you've heard, our committee was quite diverse. And this listing that you see before you represents only a partial portrait of our committee. We had physicians, social workers, nurses, lawyers, individuals from policy and related fields, so that it was a very rich discussion and a rich opportunity to think critically and carefully about this extraordinarily important topic.
Thank you, Phil. It's important for you to understand the process that we employed in order to come up with this report. It was an extensive process comprising over 2 years of all those individuals. There were 21 committee members, and this is a consensus report. What that means is all 21 had to agree with what is in this report. Reasonable people will differ. We had some spirited discussions, but in the end, we came to a consensus that these represented appropriate findings and recommendations that could advance the cause of improving quality, honoring individual choice, and potentially helping to reduce and stabilize costs over time. But it's about quality, it's about individual choice. The process involved 6 committee meetings. It involved extensive literature review. It involved 3 public meetings that spanned coast to coast in different cities around the country, where people had an opportunity to present their views from a variety of perspectives, which you can see. We had several site visits to appropriate healthcare facilities and where care was being delivered. We also commissioned a number of authoritative papers to help make sure that we had additional insights and more updated insights to supplement the fact-based information we had. And we provided an opportunity for individuals to be able to provide online testimony as well, so they didn't physically have to travel to where we were, but they had the opportunity to leverage technology. Before we go through the findings and recommendations, I think it's important that you understand that when you're looking at this very extensive report, and I'm assuming that you haven't had an opportunity to speed read 500 plus pages in the last few minutes, hopefully you have a chance to scan the executive summary, that there's really 3 dimensions that we're dealing with in this report. And Phil and I will go through the 5 major topics for findings and recommendations. But before we go there, there's really 3 key dimensions. Number 1, what do individuals and their family members need to do in order to take more control over their own life and their own health care provision throughout their life, including at the end of life? Secondly, what do clinicians and those who end up having an impact on providing care to individuals, what do they need to do, if you will? And then thirdly, what do policymakers and payers need to do in order to try to be able to help effectuate a change that we think will be in everyone's interest? We have 5 areas of finding and recommendations. Phil will cover the first 3. I will cover the last 2. The first is delivery of person-centered and family-oriented care. Clinician-patient communication and advanced care planning is next. Then professional education and development. Phil will cover those. I will then cover policies and payment systems and public education engagement. And we obviously will save time at the end for plenty of questions, and we'll engage our fellow colleagues on the committee to try to be able to help be involved in that process for responding to your questions. Phil.
So, as you've heard, there are 5 areas that we formulated recommendations about. This is a little different than many IOM reports, which have many recommendations. We made the decision that we wanted to really concentrate our efforts in a few selected areas. And while each is discrete, you will hear today how they're interconnected as well. And I would further state that as you look at the recommendations in more detail, every word in one way or another matters. They have all been debated and articulated and shaped to try and convey a very clear message. So the findings that led to the first recommendation are things that we've already begun to talk about. The recognition that people nearing the end of life face many different transitions. This is part of our healthcare system in general and part of the problems associated with them. And this places a real burden on individuals and on their families. We know that by supporting patients well, including palliative and hospice care, that we can actually increase the duration of life and make it more successful for those who are living it through the end of their death. But unfortunately, timely referral to these services, whether it's palliative care or hospice care, tend to be slow and incomplete. So because of that, our committee recommended, first recommendation, that government, health insurers, and care delivery programs, as well as private insurers, should cover the provision of comprehensive care for individuals with advanced serious illness and those facing the end of life. And we go on to define what we mean by comprehensive care in this report, and it includes a seamless, high-quality, integrated, family-centered, patient-centered, ideally data-driven program that is consistently available 24/7. Obviously an extraordinarily important need so that patients know where to go when they need support. And that care needs to take into account the evolving and changing features of the living experience, including the emotional, social, spiritual needs of patients and individuals which change over time. And we speak about this in a life cycle basis because of the need to think about these activities at different stages of life. It's not just about when one has an advanced illness, it's their whole life journey. We know that that care, if it's going to be delivered effectively, must be done so by individuals who are competently trained to do so, and that it needs to be coordinated and efficient, and it needs to be interoperable. This is particularly important when we get to recommendation 4 and we're talking about electronic medical records, so that the interoperability is sustained wherever the patient happens to be. And as we underscore over and over again, it needs to be consistent with the individual's values, goals, and informed preferences. We concluded that really focusing on the quality of the life of the individual would guide every other part of this discussion. Now, we further consider the fact that in the delivery of this comprehensive care structure, that we believe that all people, all Americans, should benefit from access to palliative care services or, when appropriate, hospice care services, particularly at the end of their lives, but palliative care services during advanced diseases and serious illnesses. That these should be interdisciplinary, because we're not just talking about, obviously, care delivered by doctors. We're talking about care delivered by nurses, social workers, pharmacists, clergy, members, a broad team of individuals who come together, but who must be adequately trained to deliver that care. And it needs to be characterized by transparency and accountability. And it further needs to have as a characteristic the opportunity for individuals to make positive choices and negative choices, that is, if they don't wish to receive certain aspects of care. In order to achieve comprehensive care, we knew that we needed to engage individuals in discussions about what end of life is about. All of us are aware that we've, over the last years, mainly focused on advanced directives as a way of thinking about end of life, a kind of checklist approach. And while that may be of some benefit, few really utilize it well because the choices change over the life cycle. And so we believe that conversations can and should and must happen at different points in time. When you're getting a driver's license, when you're getting married, when you have children, if you have an illness, certainly when you sign up for Medicare. These are points in time when discussion should take place. But if the discussions are going to take place, and as Dave Walker stated, if individuals are going to be in control of those discussions, they have to be met by providers who are able to engage in those discussions actively. Most people would choose to do that if they had the opportunity to do it. So frequent conversations need to be part of the process, and there need to be incentives to accomplish that. So to accomplish that goal, our second recommendation speaks to the importance of professional societies and other organizations establishing quality standards, just as they do in other parts of medicine, but focusing on quality standards that deal with the patient communication, the conversation around death and dying, end-of-life care, and that those need to be really driven by actionable, measurable, and evidence-based criteria. We further believe that those standards should change as the needs of the individuals change over time, that they should be incorporated by payers and providers into the quality metrics that are going to be used to evaluate patient, physician, and healthcare provider performance, and importantly, that they become part and tied into the payment system itself, so that individuals' compensation, reimbursement, whether it's a physician or a system, is connected to these quality standards. We want all individuals to have the opportunity to participate actively in these dialogues. And in order to have these high-quality conversations happen, they need to take place in a manner that allows individuals to visit and revisit them over time. Now, the ability to carry all of these conversations out is built upon the concept that we need physicians and nurses and other providers to be competent in this. And so we think that the establishment of a specialty practice in hospice and palliative care are really major improvements, and those need to be further enhanced and facilitated over time. But there are problems that need to be reconciled, and these include insufficient attention to palliative care in medical and nursing school, as well as other professional schools. The fact that we live in a world of educational silos and development silos and practice silos, and that there are really deficits in equipping providers and physicians with sufficient communication skills. This is not just an end-of-life or advanced serious illness issue. This transcends that topic quite broadly, but it certainly comes to clear and sharp focus in this arena. And because physicians and health professionals are not always so well educated, we believe that steps need to be taken to allow this to happen. And here we mean that educational institutions, credentialing bodies, accrediting boards, state regulatory agencies, healthcare delivery systems, and organizations need to establish appropriate training, accountable training, certifiable training, licensure requirements that strengthen the ability to deliver palliative care knowledge and skills for all clinicians who are involved in the care of individuals with serious advanced illness. We recognize that those who have specialty training in palliative care do this excellently and well and can serve as models and educators, but it needs to be part of the repertoire of everyone who's involved in the care of patients with serious disease. So specifically, we think that this needs to be done and accomplished and be done in a competent way in terms of basic palliative skills, including communication, interpersonal skills, collaboration, and symptom management. These are things that when I say them seem self-evident, but it is sadly not evident in the reality of the world that we face today. Educational institutions, therefore, and professional societies need to provide that training and make sure that it is happening with true excellence, and accrediting organizations need to assure that this is taking place in an effective manner. This goes on, and I just will amplify by saying that it is part of the broad regulatory component of the healthcare system to be sure that all the places intersect and connect to assure high quality care.
Now we'll go to policies and payment systems, key findings and recommendations. And before we do, one of the things I think you'll notice is my personal experience has been that you have to have three things for any system to be successful and sustainable. You have to have properly designed incentives that encourage people to do the right thing and discourage them from doing the wrong thing. Adequate transparency to provide reasonable assurance they will. and appropriate accountability if they don't. And I think if you take those three concepts, it can apply to healthcare, it can apply to end-of-life care, it can apply to education, many other things. But let's talk about incentives. Our first finding here was that current Medicare payment systems provide for some perverse incentives, and in fact, in other cases, doesn't incent and pay for things that should be paid for. We find that the current practices result in more acute care, and also more transitions among different care settings, late enrollment in hospice when you look at the data as compared to theoretically who's eligible, and that all of these things can jeopardize the quality of care near the end of life, and they can also add to the total cost of care at the same point in time. Secondly, we also find that the world is living in silos. And that such is the case with regard to health care and the division between health care and social services. Social services that are important to individuals as they enter the final phase of life. And our view is that we need to pursue a more integrated approach that will integrate health care and social service provisions for those that are entering the final phase of life in order to reduce hospitalizations, in order to reduce more acute care, that again, can improve the quality of life, be more consistent with what individuals seek based upon their performance preference, and at the same point in time can help to contribute towards reducing cost over time as compared to the status quo. Palliative care services, including hospice. Palliative care is not the same as hospice. Palliative care is involved in hospice, but palliative care is much broader than hospice. That we need to do to promote more palliative care services in order to improve patient outcomes, reduce related costs, and again, lessen the need for acute care services. There's a need for appropriate quality standards and measures, additional transparency with regard to those in order to make sure that whatever is done here does not end up adversely affecting the quality of care near the end of life. Now, with regard to our recommendation, we're basically saying that federal, state, and private insurance and health care delivery programs and their payers need to take a more comprehensive and integrated approach for determining what is covered and what is paid for those individuals that are nearing the end of life. Clearly, there are things that can be done without legislation, and in fact, I might note that there are certain private payers that are already adopting a number of the practices that we recommend. And while I think that is laudable, and while obviously some of that might be because they want to do the right thing, I can assure you it is not totally altruistic. And so therefore, I think they can see that you can provide more quality of care consistent with individual preferences, but by doing so, they believe, as we do, that you can end up reducing certain acute care and other services that can help on an aggregate basis. So we're saying to the extent legislation is necessary, that it should be enacted, but that in some cases existing authority may exist, including for CMS or others, to do this. The federal government is the single biggest payer for health care, directly or indirectly, and so clearly it has the ability to help move the market by making changes here. But as I noted before, there are certain private payers that are already ahead of the federal government with regard to this area. And that the federal government should encourage all other payment and health care delivery systems to do it to the extent that they do not directly control or regulate them. With regard to specific recommendations, we believe that financial incentives need to be provided to provide for certain medical and support services that result in decreasing the need for emergency room and acute care services, that provide for more coordinated care across various settings, including in the home, which many people would much prefer to have rather than being transported via ambulance to an inpatient care setting. We believe that it's important that there be incentives to provide for improved shared decision-making under the life cycle approach that Phil talked about, a more comprehensive view of advanced care planning, which is not a one-time event, check off the boxes and we're done with it. We believe that this information needs to be incorporated into electronic health records so that it is kept up to date. It is available on time in the setting by the people who need to use it in providing that care. And we think that steps need to be taken to try to encourage the states to develop physician orders for life-sustaining treatment, so-called POST, or other types of mechanisms that that evolve over time, but that are really consistent with the findings and recommendations that we're making here. Very importantly, all of our recommendations are focused on the individual. They're focusing on trying to understand and honor individuals' values, goals, and informed preferences. We have a very diverse society, the most diverse on earth, and different people have different preferences based upon their ethnicity, based upon their personal values, their religious beliefs, etc. And one-size-fits-all approaches don't work. We also need to make sure that we recognize that their preferences may change over time and as circumstances change. We believe that by adopting these recommendations, we will reduce preventable crisis, we will reduce the number of 911 calls, emergency department visits, hospital admissions. That can help to contribute to not only funding any additional social costs, but also to help stabilize aggregate health and social expenditures over time, and hopefully reduce them over time as compared to the status quo, which we know is unsustainable. With regard to public education and engagement, frankly, most Americans don't have enough knowledge about this, and most individuals, frankly, don't like to talk about end of life, and frankly, most physicians and other clinicians don't like to talk about end of life either. So more needs to be done to normalize these conversations, to make it, to integrate it into a number of other activities. Social trends suggest, including demographic trends, that the time is right and that the need is increasing. We believe that a wide variety of players need to engage in this process. I'm not going to read everything that's here. We're trying to move on for time. And in addition to that, we believe a number of mediums are necessary to be used. It's got to be evidence-based information that it has to involve not just the clinicians and the individual who might be the patient, but also other family members. And we also have to recognize that there is some misinformation and disinformation out there that needs to be addressed and dispelled. Last but not least on this, we note that the Institute of Medicine believes so strongly in this topic and so strongly in this report and its findings and recommendations that it has secured additional funding that for the next year there will be an effort to reach out to key stakeholders in different regions of the country to make them aware of our findings, to make them aware of our recommendations in order to help maximize the likelihood that they will be adopted. In summary, our current system is broken. It does not result in the honoring of individual preferences as much as it should. It does not result in the type of quality care that people deserve and desire. It results in many circumstances in situations that end up causing things to be not as people desire and much more costly and unsustainable than we need. And so we believe that systemic changes are necessary, dealing with individuals, dealing with clinicians and those that affect them, and dealing with policies and payment systems in order to provide for more compassionate, affordable, and effective care for individuals near the end of life. And we believe this is an achievable goal. Thank you very much. And I think this is where you can find out more about the report. This is where you can find out more about the dissemination plan, which is the 12-month process I talked about that is being developed right now, will be rolled out. And now let's turn it over. I'm going to turn it back over to Phil so we can end up hearing your questions and engaging our fellow committee members on responses. Thank you.
And again, thank you to the entire committee and everyone here today. Jennifer has, I'm sure, some practical suggestions about how we're going to handle this, but I'll give you my view, which is we are now very eager to hear your questions and comments. I'll kind of serve as the quarterback for this part of the process. So we have a group of experts who represent each of the 5 recommendations and more. And so we're going to ask them to respond to some of the queries that you have. We're quite receptive to continuing to receive questions after this event is completed. So this is just the beginning, not the end, because part of the conversation that we're having has to be with each of you as well, because we believe that you can help facilitate this conversation with a much broader community beyond even those who are here today and those who are on the webcast. So Jennifer?
Yeah, those of you in the room, if you want to ask a question, please stand up to the mic so those viewing the webcast can hear. And I ask if you please identify your name and your affiliation when asking a question. And for those of you on the webcast, you can ask a question as well. Just be sure to follow the instructions on the screen.
Great.
We have 2 mics, one in the middle and one on this side of the room. So go to Madam Rep.
Yes.
I'm sorry. My name is Naomi Nyerman. I'm formerly with the American Hospice Foundation. So, David, you mentioned fee-for-service not working well, and I'm wondering if you also addressed in the report the fact that per diem financial structure is also to be questioned as a way of creating the right incentives. That's the way the Medicare hospice benefit works right now, and that too, I think, could be reviewed as to its efficacy in generating quality of care. So that's just a comment. I also have a question. You mentioned that in order for the system to work better, we need accountability and transparency. And I wonder if in your report, in this big report, you actually addressed how those 2 things would be generated, accommodated in a healthcare system where public engagement is to educate people, but also to give them feedback about the quality of care that providers do give and the extent to which the public can vote with their feet if they were given the kind of information they need about the performance of providers. I'm wondering if that was addressed in the report, and if not, how it might be in the future.
Well, I'll start, and then Leonard or others may want to jump in. I mean, the bottom line is that we were true to what I said. We focused on incentives. We acknowledged the need for transparency and more accountability. We called for the federal government to require for its, for providers that it pays for to provide more transparency, not only with regard to quality, but also with regard to cost. It's frankly a real question as to why in 18% of our economy, which is healthcare, we actually have less transparency and accountability than we do in others. And so clearly there's more that needs to be done in order for people to be able to make informed choices, in order to be able to accomplish these recommendations. We didn't get into the level of detail that you may want, but nor do I think it would be appropriate. Phil, do you want to add something?
Yeah, no, I do. I just want to be sure that we ask Judy and James to comment on this as well.
And Jean was part of the chapter that you can see on delivery of care. And in your insert, you'll see also we talk about some of the parameters of quality of care. We didn't go so far as to speak to specific report cards or anything like that, but when we talk about accountability and transparency, when we're talking about some of the systems, we're saying that, and very much so, that that's what's needed to be put out to the public. We also call for and speak to the fact that we know that hospice has just started to report on certain quality measures. Beyond that, we also know that some of the experiments going on under ACA don't speak to some of the things that we need for people with serious advanced illness, and we call for that as well. Jean?
James, thank you. And James, on the quality metrics regarding the compensation?
Sure. So thank you for that question. One of the areas that we think is centrally important to this is communication. And the quality of communication. It's not enough simply to have the conversations, but those conversations must be of very high quality. And so one of the pieces that we advocate in the report is that measures be created for the quality of communication, that that then communication quality is measured, is reported, and that it's paid for, that how that communication quality for a physician or for an organization would actually reflect upon payment, and that also credentialing and other kinds of activities would also be able to come back to that. So that, because that's something that right now, although it's what people consider to be centrally important to their care, particularly at the end of life, there's absolutely no monitoring of that. So that's something that we specifically advocate for.
Thank you. And so as you look at the report in more detail, you'll see that we've actually tried to specify a wide array of activities that can be done, many of which can be accomplished in the immediate future without additional resources, just by individuals and organizations and societies and the federal government engaging in this process. We need everyone to do their part. Yes.
My name is Cheryl Aranella. I am a palliative physician, but today I'm here in my role as a consultant working with Daleview Associates with the Coalition for Supportive Care of Kidney Patients. And we did provide testimony, both oral and written, to the committee. I know it's obvious to me, and it's probably obvious to you, that all of these recommendations apply to the field of nephrology and to patients on dialysis. I'm afraid, though, that it wasn't pulled out specifically, and I think others, such as nephrology field in general and Medicare and other policy bodies, may not connect the dots. And I really would like to hear you say that, yes, this does apply to people with advanced kidney disease, and especially to patients who are on dialysis. Even though it's a small proportion of the people who are dying in our country, 2%, it's a disproportionate amount of the spending from Medicare, upwards of 10%, and the percentage of perhaps inappropriate use of dialysis in the frail elderly is escalating alarmingly. So I would like to hear from this body that nephrology is included.
Thank you very much. I'm going to ask Dr. Kuckner to respond.
Thank you for that comment, Dr. Aranella. I could both. In the delivery of care chapter, in the details of it, which clearly you guys just got, we tried to really focus on what is the broad spectrum of different types of patients with some, and there's some more detailed examples in there. So I think you will find it there in the details of the delivery of care chapter. So thank you for making that point.
Suzanne Mintz, Family Caregiver Advocacy. Let me first apologize for my hacking earlier in the meeting, and let me congratulate you on all of your hard work and your report. A lot of what is coming out in the summary is not necessarily new, and I'm wondering what you think is the most innovative recommendations that you've put forth, and which of the recommendations can be implemented quickest? And then I have a comment subsequent.
Bill, would you like to make a comment on that? Suzanne, there are many things in the report that may not be new, but I think this report is really comprehensive and really compelling. And today is September 17th. I think we sort of see this as day one of this report rather than the end of it. There are people all over this room who represent really important organizations with big constituencies, big and small. And so all of us, I think, can work together to advocate for the recommendations in this report. And when you have a chance to review it, you will see that that taken together, the report really represents, I think, a big difference, a big opportunity. And also, to quote Dr. Zhao, who is very, I think, supportive of this, and the IOM is going to take this forward as well as all the rest of us, the time is now.
Oh, can I,
We're sorry, we're kind of limited with time, so but feel free to talk to the committee after the.
One thing I would say very quickly, I think one of the things that clearly is innovative here, there's a number, is to take a more integrated approach of looking at healthcare and social services, and not only with regard to what's provided, but how it's paid for, and also a broader perspective on not only what's provided, but where it's provided. And obviously how you get paid matters, so that's a key part of that recommendation.
just let me suggest that you look at the Narrative Matters article in the current issue of Health Affairs, because it recommends some policy issues that tie in but go beyond what you have here.
I'm Peggy Eastman. I'm a writer for Oncology Times newspaper, and I've been hearing for years that patients are referred to hospice much too late to get the benefits out of hospice that it can provide. And I've had some experience with this with a family member. So my question is, I guess, is there still some stigma, some fear, some concern about the word hospice, and when a patient, let's say a patient with cancer, advanced cancer, when it is suggested to that patient, to the family, that they have hospice, there's still a feeling of, oh, this means everybody's given up on me.
Thank you for that comment. I think that is an area that really brings up the importance of, I think it's the third area that they've talked about, of the public engagement, of really understanding what it is, as well as on the clinician side, that the second area, we need the clinicians to understand what hospice is and what palliative care is, so that they can be best describing it to patients, and then engaging from a public side as well, so that and many other misperceptions are corrected.
And I would just add to that for a moment that, from the perspective of oncology, there is still very much the mindset among oncologists about the importance of continuing treatment. And this is where there's a dissonance that sometimes arises, unfortunately, between hospice care and treatment. And we think that that's an area that, again, requires additional dialogue. And in palliative care, treatment continues together with the support services. That's a model that we think is particularly worthwhile.
Now we're going to take a question from the web.
Hi, this is a question from a webcast viewer. This comes from the director of the Center for Ethics at MedStar Washington Hospital Center. Their question is, what does the committee recommend for situations when the values of the patient or family clashes with what the physicians or clinicians feel are appropriate medical care?
If he doesn't, I'll add to that.
Thanks a lot. So I'm glad that question was asked. It's a tough question, but it's also the reality of every day in most hospitals. And so I think that first and foremost, we really speak about patient and family choice and preferences. And I just want to re-emphasize that, because sometimes those preferences are not what we, for example, in the healthcare establishment would agree with. But if we're going to respect those preferences and honor them, we have to honor them in all directions. And so that's the first thing I would say. And as far as when those preferences clash with those of physicians, we didn't really address that specifically in this report. We didn't talk about things like utility policies or non-beneficial care policies. So that was something that we didn't explicitly address, but I do think is something that's already being fairly well addressed in most healthcare systems. In terms of those kinds of policies, some states have those policies, and it's probably a good thing. The last thing I would say about this is that while those situations occur, and there are times that there are true conflicts of preference or value between a patient or family and a healthcare team, most of the time it's really about a breakdown in communication, and most of the time it's about not receiving the highest quality care that's possible. And I think that we would all agree that if that care is given and if the communication is at the level that people need, then most of those cases will be eliminated.
And I would just add one other point to that. I think those are very important statements. There's also the inverse of that happens not infrequently, which is not that there's a discord about the patient wanting more care than, let's say, the provider or clinician thinks is beneficial, but the reality that most physicians, if you ask them, and studies have been done to evaluate this, are very clear about their end-of-life preferences. They want to die at home. They want to die mainly with comfort, care, pain control, have family and supportive people around them. And yet, those same physicians, when they're caring for others, are doing the opposite. And that's driven by not really understanding or appreciating or recognizing what the needs of the individual and preferences are, and also being co-opted by many of the perverse incentives of our healthcare system that stand today.
And we are at the top of the hour, so I'm just going to have one more quick question, if you have one.
Yes, my name is Harriet Stern Warshaw. I'm the Executive Director of the Conversation Project, and want to thank you for putting people at the center of this conversation. It's really wonderful for us to hear. So quickly, the question is, have you given thought about how we bring this to the public and engage the public and break down the walls between the institutions and the health professions, and how we activate the public?
Very kind. I was struck by when you mentioned the word perverse incentives, you looked at me. There are no perverse incentives.
No comment there, Lynn.
For this. Well, as you see, there is going to be a 12-month effort at disseminating the results of the report. And beyond that, the notion is to help other organizations, institutions increase or magnify what they're doing and hopefully coordinate so that there's a recognition both on the part of the public and on the part of clinicians that we need to make some important changes. I would just conclude, as the person in charge of perverse incentives, that among the most radical parts of this report is it says the whole history of health insurance has been about reimbursing for medical care on a fee-for-service basis. And this report says that's all got to be changed. And it says if you can't do it within the current law, guess what? You ought to change the law. That is a fairly radical position for the good old Institute of Medicine.
Would you like to?
Yes, Harriet, I think that your organization, the Conversation Project, is a good example of how to engage the public and communicate to the public. And what we've said in the report is we need to do that for several reasons. We want to engage the public to generate public support for the policy changes that are in this report. We also want them to understand what kind of questions they need to ask about care, about caregiving, about spirituality, about financial situations, and so forth. And also we want them, as you are doing so well, is to have that conversation so that they can understand what they want. It's the personal choices that Dave and Phil have been talking about. So we think we have the right objectives. We think we have the right sense of direction. And what we have to do now, I think, is all pull together to get that out there.
Great. Yeah. Thank you.
And I totally agree with that. And I would just add one last comment, because I know we're coming to the end. And that is that as you have a chance to look at the report, I think it's important to look at it in its interrelatedness. It would be easy to pick out just one area, one chapter, an area maybe in your interest and focus on that. But I think you'll see as you look at the recommendations and read the details that they're all connected together, and that it's the connection of them that really transforms this whole area of advanced serious illness and end of life. And that's what we hope you'll take away from this and that we'll be able to work on as we go forward. So thank you all for being here. Thank you, Dave, for your leadership, and thanks to the committee. And we want to thank Dr. Zhao. This is one of his first times to have a chance, number two, but the most important, to speak. And we're really pleased that you took the time to be with us today. Now, Jennifer, back to you.
No, I'd just like to let everybody know that this briefing will be archived on the Institute of Medicine website in a few days, so you can watch it again if you want to.
So there is no end of life of this briefing.
Thank you all for joining us.